Hey everyone, and welcome to This Explainer. Today, we're grabbing all those complex, dense guidelines from vascular access specialists and turning them into a practical, actionable playbook made specifically for you, the bedside nurse. Look, if you're a non-vascular access nurse, you are literally the first line of defense for your patient's safety, right? So our goal today is to equip you with the precise, everyday knowledge you need to maintain peripherally inserted central catheters, or PICC lines, safely and with total confidence on your unit.
Okay, let's dive right into our roadmap for daily PICC line maintenance. We're covering the landscape, the gatekeeper, the scrub standard, safe flushing, preventing occlusions, and finally, the shield.
Starting off with Section 1, the landscape, understanding the PICC.
So, to really master caring for a PICC, we first kind of have to understand why it's even there instead of a standard IV. It really all boils down to the medication and the anatomy. You see, a standard peripheral IV is placed in a superficial vein, which has pretty low blood flow. Our sources use this brilliant analogy. Infusing a really harsh medication, like a vesicant, into a tiny peripheral vein is basically like pouring acid down a drinking straw. It absolutely wrecks the vessel wall. Now, a midline goes a little deeper into the arm, but it still doesn't reach the central circulation. But a PICC line, well, it's peripherally inserted, sure, but it terminates centrally, right near the heart in the lower superior vena cava. This central placement gives you that massive, high-volume blood flow needed to instantly dilute harsh meds or total parenteral nutrition. And they come in a few different sizes, like a 4 French single lumen, a 4 French double lumen, or a 5 French triple lumen. Realizing that this line is a direct, open highway straight to your patient's heart, that literally dictates exactly how strictly we need to treat it.
Section 2, the gatekeeper, assessing the site.
Before any medication ever enters that direct highway to the heart, you are the gatekeeper. And what's really interesting about this concept is how perfectly this analogy simplifies your daily visual check. Your dressing should look like a clean window. That means no fog, zero moisture, and absolutely no lifting at the edges. If that window isn't clean, the line is vulnerable.
Here are the specific things you need to be looking for. And honestly, here is a massive pro tip for your daily workflow. You should actually be doing these visual checks while you are scrubbing the hub. We'll talk about the scrub in a second, but while your hands are busy disinfecting, put your eyes to work. Assess the insertion point for any erythema, any redness. Look for weird swelling or leaking fluids. Verify the dressing is completely intact on every single border and that the window is totally fog-free. And don't forget to confirm that the CHG gel or the Gardiva antimicrobial disc is sitting right there on the site. If any of those things are off, you've got an intervention to make before you ever even think about hooking up a flush.
Moving to Section 3, the scrub standard.
Okay, this step, completely non-negotiable. You absolutely must apply a friction scrub to the needleless connector using alcohol or CHG, and you have to scrub for no less than 5 to 15 seconds prior to administering any medication whatsoever. But here's the kicker. You then have to let it dry completely. That drying time is crucial because that's when the antiseptic is actually killing off the remaining bacteria. And remember, while you're counting out those 5 to 15 seconds of friction, that is exactly when you're using your eyes to do that clean window assessment we just went over.
Section 4, safe flushing and syringes.
Once you're safely accessing the hub, you need to verify blood return and flush the line. But this brings us to a huge point, the physics of syringe selection. This is hands down one of the most vital things any non-vascular access nurse needs to know.
So, rule of thumb, you must only flush a PICC line with a 10 cc size barrel syringe or larger. No exceptions. Never ever reach for a 3 cc or a 5 cc syringe. Why? Well, it all comes down to fluid dynamics. Smaller syringe barrels create dangerously high pounds per square inch, or PSI, pressure. When you push on a small barrel, it's essentially like turning that fluid into a high-pressure fire hose. That intense pressure can quite literally rupture the internal polyurethane or silicone of the PICC line right up inside the patient's vein. So always reach for the 10 cc barrel.
And building on that, you must never flush against resistance. If you attach your 10 cc syringe, you go to push and you feel pushback, stop immediately. Pushing harder could snap the catheter, or even worse, it could dislodge a blood clot and send it flying directly into your patient's central circulation. Just don't do it. Check for kinked tubing, make sure the clamps are open, or maybe have the patient change positions. But whatever you do, never force a flush.
Section 5, preventing occlusions.
So what happens when a line does get blocked?
Well, a major culprit is something called a fibrin tail. Basically, the body sees this catheter as a foreign object and starts coating it in a protein called fibrin. This fibrin can kind of dangle off the tip of the catheter like a little flap. To really grasp why this is such a nightmare, picture the actual cross-section ends of these different PICC lines. All the lumens end at the exact same spot at the tip. A 4 French single lumen ends in a standard open circle. A 4 French double lumen? Imagine that exact same circle but split right in half down the middle. And a 5 French triple lumen is that circle cut in half, but then one of those halves is cut in half again. So you have 1 half circle and 2 little quarter circles. These are incredibly tiny openings. A fibrin tail can act exactly like a one-way ball valve over these specific half or quarter circle ends. You pull back to check for blood, and the suction pulls the flap closed over the opening. You push to flush, and the flap might swing open to let fluid in, but it totally blocks blood from coming out. That's a partial occlusion, and it definitely requires intervention.
You can actually get fibrin and red blood cells teaming up to create these thrombotic occlusions along the vessel wall and the catheter itself. So, to prevent this junk from building up inside those tiny half and quarter circle lumens, your routine flushing technique is absolutely vital. You want to use a pulsatile, push-pause flushing technique with your 10cc syringe. This creates turbulence inside the lumen, which literally helps scrub the internal walls clean of any lingering medication or blood.
And finally, Section 6, the shield, dressing maintenance.
If you assess the site and the window is no longer clean, maybe it's compromised, loose, wet, not sticking to the skin, or visibly soiled, it's no longer a shield. It's failing. It has to be addressed and replaced immediately. And I mean immediately, regardless of when the next routine dressing change is officially scheduled.
But here is the absolute crucial point about replacing it. Dressing changes for central lines are not just a clean procedure. They must always be performed using strict sterile technique. No cutting corners here. We're talking donning sterile gloves, using a CHG friction scrub on the skin, allowing that skin to air dry completely so the antiseptic actually does its job, and then carefully applying the securement device and a brand new, pristine, transparent film. You are entirely recreating that perfect, clean window from scratch.
And that brings us to the end of the playbook. You've now got the fundamental tools to fiercely protect your patient's central lines. From knowing the difference between a simple peripheral IV and essentially terminating PICC, to mastering the strict 5 to 15 second scrub rule while assessing the site, to understanding exactly why those 3cc and 5cc syringes are so dangerous. So I'll leave you with this thought. Will you check for that clean window, and will you confidently advocate for that 10cc syringe on your very next shift? Thank you so much for joining me on this explainer, and keep advocating for your patients out there.